I'm here to say I'm on my way, what will I do?
Good afternoon. My name is Josefina Santana. I'm a second-year resident of maxillofacial surgery at Universidad de Chile, and on behalf of my colleagues, I welcome you to a new seminar organized with academics from the Department of Oral and Maxillofacial Surgery of Universidad de Chile. Some indications for the webinar's correct development. During the presentation, we strongly ask you to have your microphones turned off. If questions arise during the presentation, we will have the opportunity to answer them at the end of it. Questions should be asked in the chat directed to the account Preguntas CMF. At the end of the presentation, if time permits, it will be given the option of asking questions by raising your hands. Regarding the certification of this activity, at the end, an email will be sent to you to complete your data in order to receive it. Next, Doctora Erita Cordero, member of the Department of Maxillofacial Surgery of the Faculty of Dentistry of Universidad de Chile, will present Dr. Padwa.
Thank you. Thank you, Josefina. Good afternoon, everyone, and thank you for your attendance to this important event for our department. It's for me a pleasure to introduce Dr. Bonnie Padwa. She received her DMD from Harvard School of Dental Medicine and her MD from Harvard Medical School. After finishing her oral and maxillofacial surgery training at the Massachusetts General Hospital, she completed a craniofacial surgery fellowship at Boston Children's Hospital. Dr. Padwa is an associate professor of oral maxillofacial surgery at Harvard Medical School and Harvard School of Dental Medicine. She is the Leonard B. Cavan DMD, MD Chair of Oral and Maxillofacial Surgery and the Oral Surgeon-in-Chief at Boston Children's Hospital. Dr. Padwa has a special interest in treating patients with cleft and craniofacial deformities, and her clinical research is centered around this patient population. She has authored more than 175 scientific articles and book chapters and has lectured both nationally and internationally. It's for me, again, a pleasure to see you, Dr. Padwa, and please, we are looking forward for hear your conference.
Hi, I'm just going to confirm you can see my screen okay?
Yes, we can.
Okay, perfect. Well, good evening. It's really a pleasure to be here. It's nice to see Arita again. She spent some time with us in Boston. And of course, it was my pleasure to join you this evening and talk about orthognatic surgery in the growing patient. Clinicians are faced with the challenging dilemma of time and growth when treating children with mandibular, maxillary, and midface deformities. In general, surgery is reserved for patients who do not respond to orthopedic growth modifications and for patients whose deformities are too severe to camouflage by orthodontic tooth movement. Surgery prior to complete skeletal maturation introduces growth as a confounding variable that makes treatment outcomes less predictable. When planning orthognatic surgery in growing patients, it is important for the clinician to understand the timing and progression of craniofacial growth and development. Just to review, for the residents on the call, the orbit attains 90% of its dimension by 7 years of age, while bizygomatic width continues after age 13 years. Nasal height, depth, and inclination are essentially complete in girls by 16 years of age, whereas they continue to increase in males up to and beyond 18 years of age. Singh and Savara found that anterior-posterior maxillary growth is largely finished by the beginning of puberty, and any further growth is predominantly in the vertical plane. The steepest slope of maxillary growth occurs between 10 to 12 years of age for girls and 1 to 3 years later for boys. Transverse maxillary growth ends with eruption of the permanent second molars. Growth and height of the maxilla is a result of bone apposition on the alveolar process when the permanent teeth erupt. Growth in the anterior posterior length of the maxilla occurs at the sutures of the palatine bones and by apposition at the maxillary tuberosities. This graph depicts general body growth and maxillary and mandibular growth from birth to 20 years of age as a function of the percent of adult size. As you can see, maxillary growth does not exhibit the adolescent increase seen in the mandible. The pattern of mandibular growth more closely follows general body growth with acceleration during the pubertal growth spurt. There is a close relationship between body height and development of the mandible. Mandibular length and body height both exhibit a growth spurt between ages 9 to 13 years in females and 11 to 17 years in males. Mandibular growth in girls is usually complete by 17 years or even earlier, depending on the onset of menses, but in boys, it can continue until after the age of 20. Overall growth curves become flat between the ages of 16 and 18 years in girls and 17 and 19 years in boys. For girls, it's a lot easier to predict the completion of skeletal growth because most girls complete skeletal growth about 2 years after the onset of regular menses. Boys, on the other hand, really hard to predict. I always tell patients, kids are not like turkeys. Well, they are in some respects, but there's not that little timer that pops out when the turkey's cooked. So we just don't always know, but these are some general parameters that we use. And although these parameters are useful, there's really considerable individual variation in facial growth, which makes predictions from these general databases not necessarily that helpful to the clinician trying to decide on when to perform orthognatic surgery in a young patient. In general, there are 3 growth patterns for dentofacial deformities in children: proportionate, favorable, and unfavorable growth. Proportionate maxillary and mandibular growth occurs when a deformity that exists early in life will similarly exist at the completion of facial growth, such as in this patient with mandibular hypoplasia. Favorable growth is where the initial deformity improves with growth, such as this infant with row band sequence. And unfavorable growth is where the initial deformity gets worse with growth, such as in this child with a bony ankylosis of the right temporomandibular joint who develops mandibular asymmetry with deviation of the chin point to the ankylosed side and a cant of the occlusal plane up on the affected side. Many of the goals of orthognatic surgery in children are similar to those in adults, such as improving mascatory function and facial appearance and assisting in occlusal correction beyond the range of orthodontic treatment. But in growing patients, orthognatic procedures are also done to enlarge the upper airway in patients with syndromic and non-syndromic micrognathia and to aid in body image and psychosocial development. There are 2 main theoretic concerns with regard to orthognatic surgery in the growing patient. The first is, will the operation, which produces stable results in adults, produce comparable results when performed during growth? Another way of asking this question is, what is the influence of postoperative growth on the stability of the surgical result? And the other concern is, what are the effects of surgical manipulation on the remaining development of the operated and adjacent facial structures? I will try to address these concerns in this lecture by presenting the available data that exists for a variety of dentofacial and craniofacial anomalies and the surgical techniques used to correct them. Orthognatic surgery in young patients is safe. Precious and colleagues retrospectively reported no incidents of emergency release of intermaxillary fixation, infection, loss of teeth and bone, or nerve injury in young patients having an operation. Why consider orthognathic surgery for children? Because although delaying an operation until maturation minimizes the risk of outgrowing the correction, particularly in growth excess conditions, this approach is not always pragmatic and in growth deficiency conditions is not necessary. Delaying the operation until skeletal maturation is achieved in boys often extends the orthodontic treatment throughout high school and into college, which is not always in the patient's best psychosocial or oral health interests. When contemplating orthognathic surgery in a child, the surgeon should consider the patient and family history. In young females, the onset of menses is a helpful guide. Most girls complete skeletal growth 2.5 to 3 years after the onset of regular menarche. A recent growth history and change in shoe size may also indicate active general and facial growth. Additionally, facial morphology, facial size, and proportions, as well as occlusal relationships, may be consistent within a family. This information may help the surgeon and orthodontist predict future growth and help them make rational treatment decisions. Serial clinical examinations documented by photographs, cephalograms, hand wrist films, and dental models are essential to document the rate and vectors of growth. Occasionally, a CT scan and skeletal scintigraphy with technetium-99 methylene diphosphonate, either in a planar image or single photon emission computed tomography as SPECT image or SPECT scan, are indicated to help determine the status of growth. Accurate diagnosis and careful treatment planning, taking growth into consideration, are critical to achieve a successful result in the pediatric orthognathic surgical patient. A frank discussion with the child and family regarding the indications, potential risks, particularly the potential need for additional operations, and expectations of the procedure is especially important. Mild mandibular hypoplasia may be initially treated by orthodontic maneuvers that camouflage rather than correct the skeletal deformity. The success of orthodontic treatment depends on the extent of the mandibular deficiency, amount of remaining maxillary and mandibular growth, patient cooperation, and the type of mechanics used. There are few reasons not to attempt these modalities in patients with minor or mild mandibular hypoplasia prior to surgical correction in some patients, but there is little reason to continue these forms of treatment if the growth response is not favorable or if the mandibular deficiency is excessive. The consensus in the literature is that mandibular advancement in children can be performed safely and with no adverse effect on lower jaw development. Young patients have further growth following mandibular advancement, but the majority of this growth is expressed vertically and results in minimal forward movement in the dentition and at pagonion. Therefore, early mandibular advancement in the setting of mandibular hypoplasia can be expected to provide a stable clinical result when done in children. Wolford and colleagues differentiate between those patients who have mandibular retrognathia with normal versus those with deficient mandibular growth rates. Patients with normal growth are born with a small mandible or a mandible that is positioned posteriorly relative to the maxilla based on the position of the glenoid fossa. These children have normal and proportionate rates of maxillary and mandibular growth, and the rate of growth is unaltered by operative correction. Harmonious postoperative maxillary and mandibular growth can be expected with a stable surgical result. In contrast, progressive worsening of mandibular retrusion and class 2 malocclusion occurs in patients with an inherently deficient mandibular growth rate, such as patients with post-traumatic growth, deficiency, or craniofacial anomaly. In these patients, early correction of the deformity can result in recurrence of class 2 skeletal and occlusal relationships because of deficient mandibular growth. The technique of bilateral sagittal split osteotomies in growing patients is similar to that in adults. However, there are several anatomic differences that must be considered. The second and third molar tooth buds and roots may be in close proximity to the vertical cut in the buccal cortex. It may be necessary to remove the third molar tooth bud, but every attempt should be made to maintain the second molar. The location of the vertical osteotomy may need to be changed to avoid these teeth. In addition, the lingula is more posteriorly and superiorly located on the ramus in children when compared to adults. This may require extension of the medial cut of the osteotomy to the posterior border to give more surface area of contact. In addition, there may be difficulty splitting the mandible due to the flexibility of the bone, thinness of the cortical bone, and relatively short posterior vertical mandibular body height. During the mixed dentition, rigid internal fixation may not be possible because of the developing tooth buds. These are the preoperative frontal, lateral, and intraoral photographs of a 12-year-old girl with mandibular retrognathia. Here she is 1 year after bilateral sagittal split osteotomies and completion of orthodontic treatment. The jaw relations remain stable, and there is improvement in the sagittal position of the mandible. Mandibular prognathism is a growth excess condition, and latent post-pubertal mandibular growth is commonly seen in patients with this disorder. Delaying an operation until mandibular growth is complete is prudent because it minimizes the risk of outgrowing the correction. However, early operation can be carried out with no danger of untoward effects on subsequent mandibular growth. This explains the relapse potential for children with mandibular prognathism who have mandibular setback. Wolford and colleagues differentiate between normal and accelerated growth rates in patients with mandibular hypoplasia. Those with normal growth maintain the same jaw relations over time. Mandibular growth is initiated from a forward position relative to the maxilla, or the mandible is disproportionately large at birth. In these patients, operative correction does not alter the rate of mandibular growth. Harmonious maxillary and mandibular growth continues postoperatively, and a stable surgical correction can be expected. In contrast, patients with an accelerated mandibular growth rate exhibit progressive skeletal and occlusal disharmony and worsening class 3 jaw and dental relationships with time. This condition often develops during the pubertal growth spurt and may continue after corrective jaw surgery. In these patients, postoperative results are usually unstable, and another operation may be required after growth is complete. A variety of technical maneuvers may improve the stability of early operative correction of mandibular prognathism. Mandibular osteotomy accompanied by a growth-arresting procedure such as a high condylectomy or orthodontic forces using a reverse pull headgear may improve the long-term surgical results. Wolford and LeBlanc reported favorable initial results in adolescents with mandibular prognathism who had mandibular setback and bilateral high condylectomies. The use of bimaxillary surgery prior to completion of growth to treat mandibular prognathism has been proposed, but has proved to be no more successful than single jaw surgery. Overcorrection of the occlusion may also be useful, but there is no way to determine the magnitude of overcorrection needed to account for postoperative growth. It is difficult to determine with accuracy when growth is going to stop. A hand-wrist film, serial cephalograms, and recorded growth curves are all useful modalities to help predict the appropriate time for an operation. In general, the literature appears to support delaying surgical intervention until growth is complete to ensure the best chance for a stable postoperative result. However, this is not always realistic. In cases of severe prognathism, patients may suffer from problems with psychosocial adjustment, teasing from peers, and speech and masticatory difficulties. In these children and adolescents, surgical correction may be indicated prior to the completion of growth. The parents and child must be properly educated so they understand the benefits of early correction, while also understanding the potential need for an additional operation if there is recurrence based on late growth. This is a 13-year-old girl with a large cervicofacial lymphatic malformation and associated mandibular prognathism. She has an extensive anterior open bite. There is effacement of the gonial angle and overgrowth of the mandibular body. So the effacement of the angle and overgrowth of the mandibular body. The tongue is also quite large because of the infiltration of the lymphatic malformation, which has resulted in this biplanar maxillary arch and proclination of the maxillary incisors. She comes from South America, actually from Colombia, and had no orthodontic treatment. She is 5 years after Le Fort 1 osteotomy, bilateral mandibular body ostectomies, reduction genioplasty, and right before this picture was taken, she had visited us and had some further resection of the submandibular soft tissue lymphatic malformation. The open bite remains closed and the occlusion is stable. There is significant improvement in aesthetics in the frontal and in the lateral views, with a decrease in lower face height, leveling of the occlusal plane, and now her tongue is able to stay inside the oral cavity. Let's move on to vertical maxillary excess. Several authors have addressed the issue of maxillary growth and its effect on skeletal and occlusal stability after Le Fort 1 osteotomy for correction of vertical maxillary excess in growing patients. These studies have shown that Le Fort 1 osteotomy has no effect on maxillary growth and that surgical repositioning of the maxilla during growth is as stable and predictable as it is in adults. Wolford, on the other hand, observed that the most predictable results are obtained if the operation is performed after the age of 14 years in girls and 16 years in boys. He believed that if this was done earlier, there is a possibility that continued vertical growth may produce recurrent vertical maxillary excess. The literature appears to support the parameters that Le Fort 1 osteotomy should be delayed until the permanent teeth have erupted. At this stage, rigid internal fixation can be placed without damaging tooth buds. Le Fort 1 osteotomy after 12 to 14 years gives a stable surgical result, and potential for impairment of growth as a result of the Le Fort 1 is minimal. This is the frontal and lateral views of a 13-year-old patient with vertical maxillary excess. She has full tooth and gingival show in repose with a long lower facial third. As a result of the vertical maxillary excess, the mandible is rotated down and back, resulting in a retrognathic profile. The lateral cephalogram demonstrates the vertical maxillary excess. You can see the excess tooth show with the soft tissue of the upper lip. And she has good preoperative overjet and overbite with a class 1 molar occlusion. Here she is 2 years later at age 15 years with improved tooth show and repose, a shorter lower facial third, and improvement in chin position just after a Le Fort 1 osteotomy with impaction. Postoperatively, there is improvement in the vertical maxillary position and good interdigitation of her occlusion. The pre- and postoperative frontal view demonstrate the stable surgical result 2 years later at age 15 years. Let's move on to maxillary hypoplasia. Treatment of maxillary hypoplasia by traditional orthognatic surgery necessitates delay until skeletal maturity. Freihofer found unacceptable outcomes in 71% of patients who had maxillary advancement before 16 years of age, and in 46% of those patients operated between 16 and 17 years of age. Pseudo-relapse caused by continued mandibular growth after maxillary advancement occurred in 75% of his patients. In total, 55% of these patients required another operation. Freihofer recommended delaying maxillary advancement until completion of growth. Approximately 48% of patients with cleft lip and palate have maxillary hypoplasia. This three-dimensional deficiency results in a class 3 malocclusion in the sagittal plane, a narrowed arch in the transverse plane, and usually inadequate to show an overclosure of the mandible because of a deficiency in the vertical plane. Some children with cleft lip and palate have severe midfacial hypoplasia that is apparent early in life. For these children, maxillary advancement using the technique of distraction osteogenesis is an alternative to waiting until skeletal maturity. With a relatively minor procedure, there can be dramatic improvement in facial morphology and dental relations at an early age. The osteotomy can be tailored to avoid tooth buds and no rigid fixation is necessary. As sagittal jaw discrepancy increases with mandibular growth during adolescence, final pre-surgical orthodontics and another Le Fort 1 osteotomy may be required. This may involve a smaller advancement than if treatment had been delayed and the patient has the benefit of the previous procedure during much of adolescence. This is a 12-year-old boy born with a left unilateral complete cleft lip and palate who has developed significant midfacial hypoplasia in both the sagittal and vertical planes with an overclosed mandibular position. The lateral cephalogram demonstrates a dental discrepancy of 18 millimeters, requiring nearly 20 millimeters of advancement. The intraoral photo shows the dental arch just after orthodontic appliances have been placed, but before the arches have been leveled, aligned, and coordinated. Here is the same patient at age 14, approximately 18 months after Le Fort 1 osteotomy with distraction. He has better vertical and sagittal maxillary position, and his mandible has rotated down and back. The postoperative lateral cephalogram shows the new maxillary position, and because this was done with distraction, there's no rigid internal fixation. And the occlusion this is his occlusion after maxillary advancement and further orthodontic treatment. Here's the same patient at age 18 at the completion of skeletal growth with a stable surgical postoperative result and did not require another Le Fort 1 osteotomy. The profile view shows the significant improvement in midfacial appearance after maxillary advancement. Patients with syndromic craniosynostosis have little downward and forward growth of the midface after the mixed dentition, and they develop relative mandibular prognathism with class 3 malocclusion. The argument for early midface advancement has been that a well-interdigitated occlusion is the key to stability and normal growth. However, many researchers have found that after Le Fort 3 advancement, there is little growth of the midface, although the result is stable with little postoperative relapse. It appears from the literature that Le Fort 3 advancement in children has neither adverse or favorable effects on midfacial growth and no adverse effects on mandibular growth. The most predictable results for midfacial advancement occur when the operation is delayed until adolescence, usually between the ages of 10 to 12 years. At this age, the midface can be placed into its adult position, which is dictated by correction at the infraorbital rims and maxillary prominences, and not at the dentition. If the midface deficiency is severe, and the patient has malignant proptosis, obstructive sleep apnea, or significant psychosocial concerns, Le Fort 3 advancement may be done early. Conventional Le Fort 3 osteotomy with acute advancement and bone grafts performed early in life is likely to be inadequate after the completion of facial skeletal growth. Recurrent class 3 occlusion is common in this setting. The technique of distraction osteogenesis, however, has been applied to the midface with excellent results and has had a major impact in the treatment of children with syndromic craniosynostosis. The technique is associated with less operative time, morbidity, and shorter hospital stay. The midface advancement obtained with distraction has been reported to be 3 times greater than that with standard Le Fort 3 osteotomy with advancement and bone grafts. Additionally, the postoperative stability and correction of respiratory disturbance is much better with this technique. The final position of the midface should be set with the infraorbital rims and malar complex in mind. Le Fort 1 advancement will likely be necessary to maximize occlusal relationships after mandibular growth is complete. These are the before and after frontal views, again demonstrating the improved globe position and the increase in nasal height after Le Fort 3 midfacial advancement. The pre- and postoperative lateral views shows the change in facial profile from concave to convex and the increase in length and projection of the nose. And finally, to mention orbital hypertelorbitism, orbital osteotomies to correct hypertelorbitism interferes with anterior facial growth, and therefore correction of hypertelorbitism should be deferred until late adolescence. As I mentioned at the start of this talk, there were 2 major theoretic concerns regarding orthognathic surgery in children. The first was, will the operation, which produces stable results in adults, produce comparable results when performed during growth? The second was, what are the specific effects on subsequent growth when the jaws are surgically positioned during growth? To summarize, orthognathic surgery in growing patients may have a positive effect on facial growth in some patients with mandibular deficiency. Orthognathic surgery in growing patients has an adverse effect on facial growth in patients with hypertelorbitism. Orthognathic surgery in growing patients has a neutral effect on facial growth, and the results may be unstable in patients with mandibular prognathism, maxillary hypoplasia, and those patients with syndromic craniosynostosis who have early midfacial advancement. Orthognathic surgery in growing patients has a neutral effect on facial growth, and the results are generally stable in patients with vertical maxillary excess and in patients with syndromic craniosynostosis who have late midfacial advancement, and perhaps in those patients treated early with a technique of distraction osteogenesis. So in conclusion, surgery should be delayed until growth is complete in patients with growth excess conditions. This minimizes the risk of outgrowing the surgical correction. Surgical correction in children may be undertaken in certain developmental growth deficiency conditions, and the use of distraction osteogenesis may improve the results in these patients. Thank you, and I'd be happy to answer any questions.
Dr. Padwa, thank you very much for being here with us and for your excellent presentation. We have some questions from the audience. The first question is, what is the average of a second intervention in young patients?
You mean if you do an early intervention, what's the average of having a second intervention?
Yes.
Well, nobody's published that data, so I'm not sure I can tell you the exact information. If you asked me anecdotally about my own practice, I would say about 25%. But I'm very careful. I don't, it depends on the case that I'm doing. I wouldn't do a patient, I wouldn't operate on a 13-year-old boy who's had a normal occlusion and all of a sudden has over a year has 5 millimeters of negative overjet. I just wouldn't operate on that patient early. I'd wait until he was completed growth. But I would operate on a patient with mandibular hypoplasia or mandibular rectognathia early, 12 or 13. Those patients do very well in general. And the 25% are probably the patients, because I take care of a large group of patients with cleft lip and palate. So I would say of the patients that I operate on early, probably about 25% require another operation. But again, that's just my anecdotal thought, and not really, there's no real data to show that.
The second question, do you use resorbable plates?
No.
No?
Only in the cranium, but not in the jaws.
And in your opinion, what is the most useful tool to predict the growth?
Yeah, I'm not sure that I have that answer. I think our orthodontic colleagues would like me to be able to predict better than they can. I think you just have to, I use a variety of parameters. We still do use the hand wrist film, serial growth charts, serial lateral cephalograms, but I don't have any particular study that I feel. Some people like to get an alkaline phosphatase, but I don't think that there's any one study that can make you feel very confident that someone's done growing. I mean, I can remember a boy who, by all parameters, had completed skeletal growth. He was 19 years old when I did his operation, and he came back. I saw him for a 1-year post-op visit. Everything looked good. His braces came off, and he came back about 3 years post-op when he was about 21 or 22 years old and had anterior crossbite. Minor, but it was there. So he had some, and we traced the ceph. Sure enough, he had some very late mandibular growth. And I just don't think you can predict those based on any of the parameters we have for assessing completion of skeletal growth.
Doctor, and how do you manage the psychological regards in syndromic patients when you have to delay the surgery, especially regarding school bullying?
Yeah, well, we don't always delay. I mean, if kids are having significant psychosocial concerns, we will proceed with an operation. Just so long as everyone understands that this is probably not going to be the definitive operation and will likely need to do something further. But I wouldn't, if a child was really struggling at school, we would proceed. We wouldn't delay.
And we have another question. What is the youngest patient that you have operated?
For in general, or an orthognatic surgery? For orthognatic surgery?
Orthognatic surgery.
About 12.
Okay. And we have another question from Dr. Gonzalo Narea.
I can say, Gonzalo asked, hello, Dr. Padwa. Can you tell me what clinical parameters do you use when you have to determine the necessity of a second intervention in a patient?
What parameters do I use?
Yes.
So I think the parameters I would use would be if there's, the first would be if there's the occlusion is not adequate and can't be managed orthodontically. The second would be the aesthetics are not good, and we'd like to improve those if the patient and family are concerned. And the third would be if there are any significant functional concerns, particularly obstructive sleep apnea. So, if it's a minor malocclusion, it's amenable to orthodontic treatment, we'd probably just go with that route. But if it's more than minor, or if their patient has aesthetic concerns or there's a major functional problem, those would be the parameters I would use to proceed with a reoperation. Did that answer the question?
I think so.
Yeah.
Gonzalo, I think you do.
Mm-hmm. Doctor, what are your thoughts on mandibular growth, arresting procedures in patients with active mandibular growth? Specifically, how do you think about the decision between temporal mandibular joint replacement versus high condylectomy?
So I'm not a big fan of joint arresting procedures unless you can see on a CT scan that there's somebody has condylar hyperplasia, and it's not just hyperplasia of the condylar neck or the whole hemimandibular or ramus condyle unit, but that there's actually almost a tumorous growth at the top of the condyle. In that patient, I would do a growth arresting procedure. Otherwise, I generally don't like growth arresting procedures. I think violating the temporomandibular, especially because you can fix whatever malocclusion results without actually entering the temporomandibular joint. And I am not a big fan of temporomandibular joint replacement in children. Maybe for some very specific, very difficult craniofacial differences where you've tried distraction or distraction's not even possible, and you're looking at doing bone grafting, which we all know doesn't do that well and is often associated with, can be associated with ankylosis. Those would be the special patients in a child that I would use temporomandibular joint prosthesis. But I would stay away from those for routine patients who have growth issues.
Okay, Dr. Padwa, I have another question from Dr. René Rojas.
Oh,
yes, I know you know him.
I know.
Yeah, he
Hello,
says hi.
Renee.
And he says, thanks for your lecture, and he's happy to see you. And he's saying, what is your experience in maxillary protraction in case of class 3 growing patients?
Maxillary protraction?
Yes.
Does he mean with an external device, with distraction, or with the skeletal anchorage with the Bollard plates? Is there any, which type of skeletal protraction?
Dr. Rojas, can you raise your hand?
So I maybe, I don't know if
maybe he said both, maybe
both. So
yes.
I think the experience that we've had, particularly with our cleft patients, we don't even bother with a reverse pull headgear at this stage. I think that would be only useful in someone with a very, very minor skeletal difference. We probably wouldn't even see them. That would be something that the orthodontist would see. Certainly, distraction osteogenesis works beautifully. And I have a lot of experience with that, mostly in cleft patients who have really sizable sagittal discrepancies. And I'm talking in the 15 to 20 plus millimeter range. For 10 to 15 millimeters, I can usually manage that myself in the operating room. But if not, I use the rigid external device, the head frame. The skeletal anchorage for maxillary protraction, which are utilizing, people often call them Bollard plates because that's the person who made them. I think they come from Europe somewhere. They're basically bone secured hooks that are you place in on the lateral buttress of the maxilla and then in the anterior mandible. And then the kids wear class 3 elastics 24/7. And there's some good evidence in the orthodontic literature that this works well to improve maxillary growth. It works better than a reverse pull headgear where you're just pulling on teeth, because this way you're pulling on the bone. And there's some very good evidence that it works well. I put those plates in when requested by our orthodontist, but I don't follow those patients long term. So I can't really comment on how effective they've been in my patient population. I can tell you that the literature shows that it works well. And I can say that from a surgical perspective, those are a pain in the neck to put in those things. You'd think that they wouldn't be so difficult, but they're difficult to put in primarily because you don't have to use the Bollard plates, but that's just happens to be the brand name that most of our orthodontists request. And the screws and the screwdriver are very difficult to manage because they don't, the head of the screw is is almost round with very few cutouts. So just getting the screw on the screwdriver and carrying it over tends to fall off a lot. They're self-drilling screws. They're a little fussy and kind of a pain in the neck to put in, but there is some good evidence that it helps with skeletal growth.
Okay, thank you, Dr. Padwa. And the last question is from Dr. Rolando Carrasco. He says, congratulations, doctor. Thank you so much for your lecture. Do you have any specific consideration with the proximal segment regarding the condyle position in bilateral sagittal split osteotomy in a growing patient? How will you manage a post-op condylar SAG in a growing patient? Any differences?
No differences. I don't think there are any differences. It's pretty standard. You just have to do your best to try and put it up there, keep it up during the fixation, and you'll have to manage the sag in the same way. There's really no difference.
Okay.
Thank you, Dr. Padwa, for your excellent presentation, and once again for being here with us.
Yes,
It's an
you're
honor for
welcome.
us.
Thank you so much.
Thank you.
Dr. Padwa, it was so nice to see you. Thank you so much for your
Thank you
time,
for
and
inviting
I
me.
hope we can see you again.
Okay, stay safe, everyone.
You too. Thank you
Bye.
so much.
Los dejamos invitados a nuestras siguientes charlas. El jueves 22 de octubre a las 19 horas se realizará el Question and Answers con becados y postbecados de nuestro postítulo, quienes responderán sus preguntas sobre el proceso de admisión. Y el jueves 29 de octubre, la doctora Tara Halu presentará sobre la actualización de osteonecrosis asociada a fármacos en la práctica odontológica. Y este webinar será en inglés sin traducción.